personal risk factors, and economic factors. So the paradigm that we'd like to materialize, or what we want to achieve, and that's why we implemented this in different countries. And what they've implemented in other countries has been done in vertical to see what we can do after retirement. And we measure the horizontal lines here in the graph. Next slide. So we're broad in our mission and trying to improve our people's health, but this is influenced by risk factors due to the occupation of the employees. There's other elements that impact community impact, economic impact, and then we have these results. The vertical broadened image here is about the cycle, the life cycle from the previous moments of employment, because if we think about employment, it's dynamism. It's relevant for all the safety and health of the workers during their active life, but also for the health of the enterprises or companies, because both situations have a correlatable influence. Next slide. Amidst the context, this is a lot of what's happened in Mexico, and I'll share now the results, the outputs in this nation, which are pretty recent, sourced from the Mexican Institute. We are coordinating. I mean, employment, being employed is a transitory state of people, and sometimes employees transfer themselves to others. But in the Mexican Institute of Social Security, the period or the time frame in which they work or stay in a workplace, they stay 7 months and go to another job and stay 7 months. And what happens after this term is done? Or the employees go through employment conditions and unemployment. In the period of unemployment, there are losses of coverage in the healthcare system, because employment is correlated to rights, the rights to have access to that health. Second, unemployment leads us to economic losses that affects mental health. And that is how all of this triggers an accumulation, a combination of effects on health. In the case of the Mexican Institute on Social Security, IMSS, if you lose the rights to receive a service of medical nature at IMSS, has an impact. And that effect is correlatable with a loss of 43% in the quality of the attention or services, and a reduction of 12.2% in the results. For example, in the field, if you suffer diabetes, that's the percentage. In other conditions, the impact is even more dramatic. We went through research and analyzed, the issuance of prescriptions to acquire any drugs or medications for people who have a diagnosis of diabetes. Out of the workers that had hypoglycemia, they had type 2 diabetes in its initial phase, only 21.6% of them received an issued prescription during 3 consecutive years. It's very important, because once Social Security is lost, the person loses the issuance of the prescriptions to obtain medication, and there's a general loss of control, and it impacts health. Because, the traditional medications could be cheap and easy to buy, but there's patients that have to use insulin, and the controls are very strict. 32% only of the workers obtained the product that was prescribed in consecutive years. So that is part of the problem. That's very important. And we have to consider it for the proper well-being of the workers or the payroll. Now, I'll go and explain this with statistics. This is our matrix, and we've compiled data from 2018 till 2023. These data were part of a log or cutoff of the benefits that were measured. Now, these are the root causes of disability, permanent disability, or in that time frame, in those years. If you focus on it, there's trauma, and that's a field of opportunity, an area of opportunity with the employees. They suffer trauma. We have diagnostic reports and the percentages, the numbers, the quantification of the total cases of disability, hand or wrist trauma or fractures impacts are generating 20% of disabilities. Knees and legs, 5%. There, next slide, please. Here, throughout time, we can observe that the variance in the slide. The bar in the chart that's colored in brown is 2023, and the green bar in the chart are the numbers from 2018. You see that there's an important decline in the chart that enables us to see the frequency, the element of frequency. This translates into what are we doing? It might be skewed a bit, but during 2023, we quantified workers that have not yet finished their disability. So there might be a year of delay, but the difference here is important. It's relevant. So I mentioned this because we're going to see the chronic diseases that have the same behavior. I mean, they're skewed, and we're going to see the variance or the differences. Next slide. In this slide, what you can observe are the causes of disability that lead to a permanent disability. And we have quantified 178,000 that were analyzed during 2018, and we quantified them to 2023. Diabetes is cause number one. Diabetes is the root cause, and we can prevent that. But by tradition, our healthcare practitioners in the workforce or the healthcare services don't see this as part of their responsibility. It's very important for all of us to work and tackle chronic diseases to avoid having to deal with a permanent disability. Diabetes, arthrosis, the back impact, tumor or tumors and other conditions. If we branch this out with gender specificity, then we analyze what's the second cause of disability, permanent disability due to diseases or health conditions. Next slide. Here, this is the full landscape, which is the opposite or the contrary landscape. Back in 2018, even if we compile this, there's skewed issues, but we quantified the cases. We measure the frequency in these ailments or conditions. Or what I mean to say is that chronic diseases in numbers grow, and the growth is important. So this is a permanent cause of disabilities in our workforce, and that is something that triggers, and there's a reason, and this motivates us to really focus and work with our employees, but I don't know if I've consumed all my time, but let me know how I'm doing with my time. Now, next slide. I implemented a program, a government program that's very similar to the US program. It's an analog program that's called Total Health for Workers or for the workforce. These are similar or analog programs. They're compared to European programs that we implemented after we simply got back from the pandemic. And what we've been doing is fostering the creation of the right environmental or contextual corporate setting. Companies have to be very positive, and they have accepted this program very well. However, it's not a program that we can verify. I mean, it depends. We need volunteers or affiliation when there's will. In this program, we have guidelines. When somebody has an accident and has an impact on the body or the muscles, the skeleton mass, or the ankles, and we have to continue monitoring what's happening at the work site. So there's actions to follow immediately when something happens or an incident takes place at the workplace. Next slide, please. I think this is not no, that's a correct slide. So what do we want for the new ELSA program version? With ELSA, we want to create or build mature indicators, hard objective data. Right now, we're defining with the heading, what's our purpose? But you can see that the main cause of this is diabetes. So after compiling this, we have created ideas to continue working with the counterparts, which are as companies. We want to install the programs of digital therapy for recovery for patients that are living with a diagnostic of diabetes. So we want to give them therapy so they can follow up and track their disease or condition. This is data that can be verified and the workers can register. Second, we have to impose a level of control controls that the workers or the employees have. Now, these controls depend on the physicians that work for the companies. We're working to tackle breast cancer. We are analyzing a coverage of screening and breast cancer analysis after certain amounts of years, after 5 years. And, screening to detect cancer for different workers is something that we've been doing. We had a pilot program implemented in companies in which they are taught of how to detect papillomavirus or breast cancer. This really helped. This program was great in companies in that corporate setting. Now, we also have the number of accidents in the workplace. Usually, the workers that suffer this have to go through their specific checks and comply with a full scheme or program. This is we're incorporating this economic element to the general payment, and we're analyzing the insurance to see the economic factors, and in the Mexican social authorities, if they're adhered and registered with these programs, they can achieve their objectives, so they can have a cut down on the payments for the healthcare benefits if they do this. Now, I want to express this with the next visuals about the program that was executed, being in a pilot program. But so you'll see what happens in different companies. We had to submit this to test. Uterus cancer is something that could be detected in a woman in a private setting, in the restrooms of the company. They take a sample, they take it to the lab, go through the sampling process of it to see and to detect cancer, and it's cost effective. So next. Well, then that's it. Now, this shows you a bit of the entities that participated with us here. Fall back one slide. Okay, you did go back one slide. So I wanted you to see these leaflets or these newsletters that we paste on the corporate setting and the buildings and the infrastructure right at the restrooms. And we had this campaign for the workers, and 80% of the workers of many companies participated. The company that participated less in this program was measured as 64% participation of their employees, and it motivates the employers and the employees in that correlation. Next slide, please. The next visual enabled us to implement and renew or upgrade the ELSA program. We have a scorecard or a ranking executive report. If the companies use this ELSA program, we can measure and give a score or rank to the companies and award them an acknowledgement. So those are just examples of the daycares that are part of our system, daycares that are part of companies or corporations. This is created in Ciudad Juárez, and you can see it's a circular daycare infrastructure. Next slide. As a conclusion, this data leads us to focus. It's very important. It's necessary for us to include this in the risk assessment. That assessment makes us follow up on things. We have to think about the holistic conceptual capacity that we have. So this is taking into practice to improve the healthcare, the safety and security of our people in the workplace. So this enables our efforts to grow and to increase the scope of impact in the healthcare field. Thank you, ladies and gentlemen, very much. Thank you. Thank you once again, Dr. Hernandez. Thank you for opening the panel with this initial announcement, with your clear message, which we're thankful for. Not only does this attract the attention because your model integrates so many links to improve the health and well-being, the health-life balance of the workers. So it's the Engel model. And that Engel model and your model leads us to work on our clear objectives. We're all interacting with those psychological, social factors, and even we're building the strengths and health of our the employees. So the statistics that you submitted here today catch our attention. The chronic diseases have grown. That catches our eye. Permanent disability numbers caught our eye. In an organism's anatomy, it's like the traumatism in the body, in the wrists or hands have increased. So based on the countries and the data of reference and contrast, we can measure the accidents in transit to the workplace or back. And we can also, we're here to thank you, sir, for having such a clear focus about actions to prevent these conditions, implementing the ELSA tools. So, Doctor, we'd like to invite you to continue discussing these matters with us later on, because this is a case of reference of best practices for all our countries at a regional scale, sir. So thank you so much for participating today. Now, we're going to start immediately with our second panel. Edgar Velandia Vaca. Our doctor, Velandia Vaca, is a surgeon thanks to the Colombian University. He's an expert in work-related medicine thanks to Rosario University, and he's an expert in health administration through University Jorge Tadeo Lozano. He has 2 master's postgrad studies, one from the Javerian University and another in management and administration of security systems for Social Security that had been issued by the Alcalá University of the Ibero-American Association for Social Security in Spain. Dr. Velarde was an underdirector of work-related risks at the technical chamber that was constituted in Colombia. So he has served as a consultant for the World Bank and the Inter-American Development Bank. He was co-author of the books and guidelines that were created for Colombia, Bolivia, and Dominican Republic. He has a lot of experience as a scholar professor in labor medicine, health at the workplace, and Social Security. Now, he is currently working as a main physician of the initial ward of invalidity analysis in Colombia. Doctor, thank you so much, sir. The floor is yours. Thank you, Ms. Graciela. I salute you all. I thank the Inter-American Conference on Social Security and the present stakeholders. Now, I wouldn't like to continue without mentioning first, that based on experience, our case of reference is packed with experience, and we want to share the Colombian case, specifically what's correlatable to benefits if you suffer or face labor risks. And we have a structured system to score and rank the impacts of different conditions or disabilities in Colombia. Pardon, 1 second. Let me see. I would like to know if I'm sharing my slides with you, if you can visualize them. Okay, thank you. Let me close one window. One moment. Here, I'm trying to share my slides, my screen, but I don't think I'm enabled to share it. I don't have the authorization to share the slideshow with you. Well, meanwhile, pardon, I don't have a way to share my slides. Could you try it once again, sir, please? I'm going to send you my slides, okay? Of course, here you can send them and we're going to share them.
Intente nuevamente compartir, doctor.
Try once again, doctor. Try sharing now. Let's see if you're enabled. So I'm going to share your presentation if I can't achieve that just yet.
No, me está pidiendo una
Ya la
contraseña.
estoy abriendo.
I'm being asked to log in and a code. Okay, you got it. Thank you.
Bueno, muy bien.
Thank you so much.
Siguiente.
Next slide.
Ok, entonces,
There we go.
pequeñas cifras de contexto.
Just numbers to give you the general context about the case of reference, which is Colombia. Our population it's close to 50 million in population. And there's 39 million people that create the workforce. And out of these, the economically active members of the population has been measured at 24.8 million employees. So there's a rate of unemployment that's high of 11%. And those who are part of a payroll are 10,400,000 people. According to the numbers of the Ministry of Labor, all of these people are registered in the labor risk program. And on the other hand, we have like autonomous or independent workers that are another type in the Colombian nation. And they are over the payroll employees. So out of those in population, some are part of the program to prevent work risks in Colombia. Now we have a coverage close to 11,600,000 workers. The majority of these workers depend on this. In Colombia, it's possible to register and affiliate yourself to this work-related agency. We have a number. I think we have there 100,000 workers, and in the informal
Esto hace que la población.
the population, next slide, please. Okay, then. So this branches out into two. We have two types of workers affiliated to the system. That's mandatory for them to be registered. It's compulsory. And then there's the voluntary registry. Now there's independent workers. The students in higher levels of development in the field of education to register and graduate, they have to meet the requirements. They have to serve as in their internships in a companies, and the companies then would register them for the benefit. There's other workers and people that work in collective associations, those who are independent and that have signed off a service agreement with a company or an entity that could be public or private in nature. And then those who have created associations, for example, the Association of Doctors, the Association of Attorneys can register themselves to the risk method or program. And there's others that could use these government agencies when there's a disaster. There's the community of mothers is a very special population, as well as those in the transport system or taxi drivers. Some members of our societies can register themselves willingly, by their own will, and the rest of the types of workers are listed there. 10 million workers are not yet registered to our system, but next slide, please. You know, if you think about the services offered or the benefits, there's, different types. Work-related issues in correlation to benefits. There's certain terms and precariousness. We have the system to, satisfy the needs when there's issues in the general system. people can have access to the benefits and to have direct assistance and access to medications, procedures in the healthcare system. But from the workforce, I mean, there's no constraint and there's no limits, and the services are offered there 100% for our beneficiaries. If we have the medication in stock, we can give it to them. Prosthetic objects for like our people are offered if they're there. So in general, it's not that way. There's rehab programs administered by professionals. I mean, you can even find different treatments. The expenditure of transferring a patient are considered from the household to the institution where he's going to receive or she's going to receive a service. I mean, if the person has a disability, the person can, if the person is in a situation in which he or she does not have the means to go to the clinic, I mean, we have to see that the costs there are added. These are the economic benefits that we offer in Colombia. This is the general system for labor risks. If there's temporary disability, there is a redress mechanism, setting things right. There's a unique payment or installment. When a worker loses part of their capacities to execute their duties, they can be redressed. There's a pension due to disabilities, pension and other pensions during funerary services. So those are the economic benefits that are part of our system. In the temporary disability, we have this list. And basically, this is correlated to the days in which that benefit should be paid or the redress happen. After the accident happens and there's a diagnosis about the conditions, this has to be paid in 360 days, or we have to give them a disability permit that lasts 360 days, but it depends. We have a specific number or thresholds of days of leave in our calendar. The work-related risks lead us to analyze the last wage of the person.
While in health, in the general regime, is the benefit is less, 66% of the salary until 90th day, and 50% from 90 days and 150 days, without it being less than the minimum wage. Next, this is the graph that we use for the compensation, and that qualification made it something that we're going to see in the future. And with the assessment manual of loss of labor capabilities introduced into this grade in a permanent or partial compensation in number of salaries. Like, for example, a person that lost 40% of the capability to work, they have the right to 19.5 salaries, basic salaries, according to the system of labor risks system. In the case of pension, we have established it from a qualified percentage from 50% or more than the loss of work capability. So we're talking about a pension by common risk disability requires minimum requirements of weeks of work, 50 weeks in the last 3 years, while the labor work is the coverage from the following day after the worker has been affiliated to labor risk program. The amount of the benefit is different. It's greater in labor risks, reaching up to 75, and even if they need a third party, it may get to 90% of other income. While in common risk, it begins in 45, and depending on the weeks, it may reach even 75% of the basic wage of compensation. It has to do with surviving or survival pension, where beneficiaries are the spouse or minor children, or those that are older than 18 and younger than 25 that are still studying and depend on the person that passed away, and they have the right of funeral support that is corresponding to the number of salaries depending on the amount that has been calculated and depending on the amount that these funerary expenses cost. So these are the five benefits of the system. How are they assessed? And then we will have the corporal damage evaluation system. We talk about a unique manual of qualification of occupational loss. And so indeed, there are some other ways to measure this. The social security system in the general regime, especially pensions and risks, are ruled by this unique manual, while in their exceptional regimes where we have teachers, educators, they have their own decree, their own manual, and the way to grade this. Ecopetrol, which is the oil company from the state, is ruled by the unique manual of um, assessment of loss that has a general regime, and the military forces have their own way to grade this part. So there are more special programs from the state for vulnerable population. There is an instrument called the disability certificate, and with that certificate, they have access with a certain percentage to those benefits given by the state, additional to Social Security. And the Colombian manual, then, the unique manual of assessment of labor capability, their reference or the methodological reference is the International Classification of Functionality and the charts of the Medical Association from the Americas in the 5th edition and 6th edition too. So the way we apply this goes high with the previous manual. It was designed for the population to be qualified. We put aside the beneficiaries, and in this case, people that did not work or were not working, or either the people or children, the minors that we were not able to classify them with relation to the regular job, which in their case would change in the case of children or young people by study, and then in the case of senior citizens, it would be changed by the use of time. So there are some definitions of what we call the wholesome grading. In Colombia, we have the possibility that a person that may suffer from an accident or of common origin and labor origin, they would be graded together, and this would be as a result of disability. The Constitutional Court established the possibility that these people may have access to a disability pension, adding up both subsystems, and they would be in charge of the last subsystem, with which they reach that right. We establish ponderation criteria. This trying to have the Colombian guideline to the classification or the guidelines from WHO, and then we had part of this criteria from the CIF to frame the guideline. We have the maximum medical enhancement from the AMA, and the concept of charge of adherence to treatment as one of the criteria to classify this. And we establish a model of charts with main and modulating factors to work with the ranges. And we have an example of a chart, which is a chart of diabetes criteria, where on one side we see the criteria, then we have a main factor, and there are some modulating factors, and there are some classes, and each and every class has a grading range, and the main factor defines one of those classes, and that class will set the range which we are going to move with the grade with that pathology or deficiency. On the modulating factors will define within that range which would the value be that is going to take or that we are going to consider in order to define the classification or qualification. This makes it a little bit less subjective with the previous manual where we didn't have clearly established criteria. So before title number 2 or the second part of the grading, if we see the next slide, before the second part of the classification of qualification that has to do with the seat, we took some criteria within those labor role and self-sufficiency and age of work, and we took the other occupational areas such as a specific criteria, not all the seat. Colombia adopts just one part and puts aside something that in the concept of the criticism, it's something that is missing in the manual guidelines, so we would have to see it within the context, which is the contextual factors of it. So the Colombian guideline does not seize all the categories, but they don't consider the contextual factors that would have to be enhanced in some way. Next, please. So in the end, qualification or the qualification is both the sum adding up of both by the charge of the heat and the value of the second part, that is the American Medical Association, which is the chart that unifies the criteria by the seed, and these two classifications are paired to define the loss of final labor capability. In Colombia, there's a whole process that may be very long due to the great number of qualifiers that there is. There is a qualification that is performed by the administrator authority, the insurance company, the provisional insurance company, and the administrator of labor risks, or called pensions, which is called the state of pensions, state entity of pensions. So each any of those would make the initial qualification, and if there is controversy, then they go to a collegiate organization, first instance, which is the regional board. If there is controversy before there is decision that they make, there's a second instance, which is the national board for the qualification of disability. But besides this, there's the labor justice that may interfere at any moment. You can go straight to the labor justice and then get rid of these administrative passages from the very first instances of controversy. 2 minutes, doctor. Thank you very much. And then the last that I want to talk about is the way the definition behaves of a labor disease. And this is the result of exposition to risk factors inherent to labor activity, bringing the definition from the International Labor Organization. But it also says that apart from the definition, there's a possibility to have a chart of labor diseases. Colombia has a mixed system where we have a definition and where we also have a chart of labor diseases, where you would simply, you would have to make evident the cause and the disease in order to catalog it as or classify it as a labor disease. This is a chart that has a double entry, one for risk agents, and so we have chemical, physical, and biological agents, all the risk agents, and we cannot go there and search for the diseases, and a second one which is ordered by group diseases. And let's say that the chart by any of the entries will give us the same result. So there are two sections, one from the etiological agents, and there's a second section where we have the diagnosis in that section. There is something which is the novelty in the Colombian chart, which are what we call direct labor diseases. What is that? Well, this is something that very little countries in the world have. But it is when a person has a disease and that disease belongs to a specific group of economic activity, that disease is considered to be labor regardless without having a causal analysis. So in the next one, we see these pathologies. Next, please. So, well, we have four, and indeed there are five. It's pneumocoriosis, asbestosis, silicosis, pneumoconiosis of the carbon miner, and other. So if a worker is a miner and he has worked in this activity and he has a diagnosis of pneumoconiosis, that pathology is acknowledged as a labor disease, and we do not have to have any other kind of analysis. These four, there is a fifth one, which is COVID-19 in workers of health that are responsible for the direct attention of patients that are suspicious to have or positives to have COVID-19. So, doctor, practitioner, or maybe a janitor that may have their activity in a intensive care unit where we have COVID patients. Just because of that, we consider it as a labor disease. I don't think I have no more slides. Well, this is the example of the chart, and the only difference between both and not direct, which is the rest of the diseases, is that we have to show evidence, while in the diseases, direct labor diseases, we do not need to give any evidence. So this is more or less an idea of what, generally speaking, the Colombian qualification system to grant those benefits that the labor risks give before a labor diseases. Thank you very much, Professor. I would like to tell all the participants that this is a referential manual for many countries, that you have worked in the updating of this, and there are important enhancements. But the important here is that you can see from the beginning, from the kind of disability, how this is actually very similar to other countries in the region. The fact that economic benefits by disability, permanent disability, are not the same for a common disease and a labor disease. Well, there are different manuals according to the sectors. Nevertheless, sometimes the referential legal manual for Social Security is taken by other legal entities. So I want to say also and observe also that, as we first said, the trend is to approach or get to the CISS first, and this is one of the manuals. It is, and if it doesn't have the contextual factors, let's see how it follows not only the efficiency and not only the daily activities that takes. It also adds this manual something of self economic self-sufficiency and considers the age of people. But besides that, it's a whole system. To apply this, we need to have the best qualifiers, or to have experts in the application of these guidelines. So, Doctor, thank you very much for your contributions. And then we'll go straight to a great friend of the Inter-American Conference on Social Security, Dr. Grisela Olivera Roulette, who is an ophthalmologist, specialist on disability management, also in public health by the Ministry of Health of the nation. So she has three master degrees in the management of social security systems in Spain, another in public policies and administration by the University of San Andres, and the other in the administration of services of health by the Catholic Church of Catholic University in Argentina, among other. other points. Dr. Oliveira has more than 25 years of professional experience in the management of policies and programs regarding disability. Nowadays, she's an international instructor of the International Classification of the Function of Disability and Health, CIFF, from the collaborating OPS Center, Mexican Center of Classification of Diseases. Please, Dr. Roulette, it is a pleasure to have you here with us. Oliveira Roulette, doctor.
Doctora Grisel, tiene su
Dr.
micrófono.
Grisel, your mic is turned off or muted. Good afternoon. Can you hear me now? We can hear you perfectly. Sorry, Graciela. Well, it's a pleasure. Good afternoon, everyone. I really thank you for the invite. The first technical summit of the American Commissions on Social Security, because they gave me the opportunity to participate in this Social Security for disabled people. In this case, I suppose that it is clear to us to begin in some way with our speech. I don't know why don't we have the image, but anyways, is this all right? It's okay, doctor. We can see. Perfect. So you already know the panel. It's the granting of Social Security services for people that have been disabled because of labor risks and economic benefits for the Argentinian people. So I'm going to talk about the three laws that in some way give us the possibility to evaluate the disability topics. Well, when we talk about disability, the first law, it was 22,432, an integral law for disabled people, and with the possibility by the year 95, it was passed legislation on labor risks, and as well as we have from 1948, we have a provisional law that is for the non-contributed law of pensions. So I believe that in this case, most of the countries, let's say, can have access to a compensation or a pension due to disability refers to subsystems with their own regulation structure that may establish the methodology to determine the amount and the access to such benefits. But today, also most of the countries, the conceptualization of disability has changed. So the mostly used model has to assess not only the functional and anatomical damage, but also the psychosocial side of people, trying to eliminate all kinds of barriers or hurdles rather than only architectural barriers that affect all the disabled people. And regarding the non-contributive pensions in this slide, well, it's not the same, in the case that the amount of contributions that we have, and only this certification of the non-contributive pensions, as well as the law on labor risks, are assessed by medical boards, and they're not interdisciplinary. So we must find these people disabled due to their social vulnerability and health condition. From the disability point of view, the non-contributive pensions, it's also for mothers for more than 7 children or even more. So in this case, universal pensions for elderly people, and also there might be a universal pension. Next slide, please. Within the law of disability, it must be very clear that on one side we have the law for disability, and on the other side, as I said, the labor risks law, and the other one, the non-contributive pensions law. So what does this imply? That a certification, let's say, which would be the public document that manifests the disability, may accompany but it does not define from the provisional point of view. The legislation in 81 wanted to grant warranty education, medical attention, uh, and also work on the disadvantages that this disabled person may have, and involved sectors where health, education, work, and means of transportation, access, and social security. And also the actors in this legislation had the community participation headed by the state, and all the health sectors, and social civil society organizations. So if we see the evaluation of the damage and the economic benefits, then in the Argentinian context was related to the law of labor risks that would be disability or not being able to work, maybe caused by accidents or professional diseases, may be permanent or temporary, and at the same time permanent may be total or partial. And so it would be ordinary, that may be transitory or definite, or a great disability or a complete disability. So the labor disability, we have we make evident some limitations, being the 100% of the functional capability of the worker, their permanent capability. In the case of an accident, insurance companies are responsible for the coverage of the contingency, and they will have to give the benefits on a daily basis. In the first 6 months work with the rehabilitation according to the cause of the damage by professional disease, or in the case labor accident. And if there are several, the amount will be raised. So the disability suggests a professional disease, as I stated first, or even a work accident. But if we're going to talk about disability, which is paramount to consider, what the Convention on the Rights with People of Disabilities, Dr. Hill also mentioned, it defines that it's a concept that evolves and results from the interaction between the disabled people and the barriers due to the attitude and the surrounding where that avoid their effective and complete participation with the rest of the people. And this convention was passed in 2006, and the Organization of the United Nations in Paris in 2008 through a law, and in 2014 was elevated to a constitutional rank. So this is why it is giving us a great responsibility with the disabled people. So let's keep on, please. And the international classification of the functioning of disability and health in the convention, the convention considers it as a something philosophical to the definition that it seems to me pretty important, and it was passed also in the General Assembly of the WHO by all the member states. And this international classification is a document whose main objective is to give a coded language that will allow to have a unified profile and standardized profile on the functioning, disability, and the health of the person, taking as a reference their structural and corporal functions, the activities he performs or they perform, and the possibility to participate in these activities. Please go ahead. So disability, according to CISS, is a generic term that includes deficiencies in the functions of the corporal structures, but also talks about the limitations in the activity and the restrictions in the participation. That is to say, that there are aspects in the interaction between individuals with a condition of health, but there are also the contextual factors are also pretty important, mainly the environmental factors that are coded and personal ones that have not been codified by a single reason because of a race or religion. What's the background of this classification? Well, it belongs to the family of WHO family of classifications, and together with that statistical international classification of diseases and problems related to health, which in this case we are still with the 10th revision in the aspects of certification of disability, and see if they're complementary. It's not that one is more important than the other one. They complement each other. Why? Because CE will give us the classification of the health state based on the etiology or the origin of cause that provoke this diagnosis, while CIF will give us the classification of the kind of functioning and disability associated to the state of health. Please, what are the objectives of this classification? Well, it's a classification with multiple purposes to be used in several sectors and disciplines. That is to say, not only doctors work with this classification, and for sure, it has a site, as Dr. Hill said, on the biopsychosocial aspect. In Argentina, the assessing board, the basic assessing board, is made up by a practitioner, medical practitioner, a social worker, and by a psychologist. So that's the basic thing in order to have this biopsychosocial side, because not always the functional and anatomical functions give us an idea that the life of that person would continue. It gives us a scientific side to understand the health and the states of health in a common language to facilitate communication among different users. So there would be a possibility to compare data among countries, because in here we would forget something pretty important, to have our own measurements that some countries share them or not. And let's say that the common language will allow us to be able to unify data at an international level.
And also there's a scheme that's systematic that we could apply with computer science systems that are used in the healthcare units. And sometimes we face major problems. And as it was being said by the previous speakers, now the core subject about, during COVID-19, that really marked precedent at a global scale. But please continue with the slides. Ma'am, some implementations. So we have this intrinsic implementation in the field of health, and it can be used for social security in the assessment of the field of health and population studies at a local, national, and international scale. Next slide, please. And here, in this case, the universe of the CIF and its implementation, as I've told you, according to the slides here, it's universal. And we use it for, the classification serves us to assess people who live with a disability and consider the healthcare capacities and what's correlatable to in all our people. Next slide. In this case, CIF describes situations related to human functionality and their restrictions, structuring the information in two branches of a very significant way. It's interrelated and accessible. Next slide. And I think that this CIFS, I'll ask you to give me an extra couple of minutes, because I think it's very important for me to let you know what the CIF is. I know that you have the general understanding of it, but it's constituted by specific elements that are functional to measure disabilities. We measure the corporal capacities and the activity and the participation of the subjects. And the contextual factors, as I've told you, are environmental, and there's personal factors that have not yet been codified. In the first level of classification, we're going to find what we call areas of dominion. That's a cluster of relevant practices and reactions of the organism and tasks. And this assessment is something that's bodily. It's like the body of the measurements, and we classify them in B8 or B1, S8, or E, and the activities and participation is measured in D1, D9. And then there's environmental factors classified under E1, E5. 2 minutes, ma'am. Yes. Now, here for you to observe, what we have is we measure B, letter B, corporate functions that are correlatable to the corporate structure of the organism. Next slide. Here we have activities and participation. We go through the thorough assessment of that person, the body of the person, and what she can do if we give them that support. And the environmental factors are not less important. We assess products, technology that makes it feasible, the natural general context that affects a lot the workforce, and family is another factor. Experts that help, capacity, skills are factors that are also correlatable to traditions, what's customary, and even ethnicity and other factors as well. Next slide. From now, in this slide, there's specific components. There's the minimum components, and after components, you go follow the arrow, and we go from the general data to the specific data. And let's continue this analysis so we have enough time for the rest of the keynote speakers, and I want to respect the next keynote. So let's continue with the slide. But for this, we have ways to score it, to rank things, and how we qualify or assess, rank the grievances of the problem that we evaluate. We codify this to rank and score with decimal points. I mean, if you have a point in the score, that's something that's an obstacle. If it's a positive point, it's something that facilitates it. If we don't have a score, coding this would be senseless. Then we would interpret it as the absence of problems. This has to be clear. Disabilities are part of all human conditions. So please, next slide. And as I was telling you, the correlation with environmental factors in this assessment, if we speak about the labor, the workforce, and we see these environmental factors that I've already discussed with you. As a matter of conclusion, in this slide and next slide, just to finish, these are the tools that measure with precision the reality. And this is our part of the recommendations. The kickoff point is we assess the health conditions to define the profile of the person and its functionality. We need to work with multiple disciplines to really measure the level of disability and how that disability changes throughout time to create intervals to analyze the profile of a subject. Thank you for giving me the opportunity to share this information, and I'm thankful, and I'll see you later. Thank you, Grisel. It was an honor for us to listen to you over here. So it was great for you to show us your slideshows, and you ratify what you said and what we've said from the beginning. What we have to do to finally evolve and understand the concept is we must evolve and go through the thorough assessment of people that live with a disability. If you have a classification, if you have the different types, a standard, a unique language to compile all the elements or factors. It's not just to measure the deficiencies. There's factors which are environmental or personal factors that must be part of the assessment. For the majority of the participants, it's not that easy. We have the same, you're an expert in your profession, in your field. So you are a civ trier of fact. You're assessing this to measure disabilities, and this could be implemented in many sectors in different fields, but it's very important to show all the participants, the complexities and the needs we have to really rank a disability. It's not that simple, right? It's not that simple. Many years ago, we used a table, a chart, or a matrix, and then we assessed each part of the body. Today, we measure other elements too. Thank you so much for reminding us about this method and raise awareness. Immediately after thanking Dr. Grisel Oliveira, we would like to also welcome to the panel. We'd like to thank those who are part of the panel. Now, Dr. Henry Jimenez Naranjo. Sir, Dr. Henry Jimenez Naranjo has a degree in medicine and surgery. He has a field of expertise in labor-related healthcare sciences, a master's in as an examiner, that creates general examiners files in Barcelona, and he has post-grad studies in administration of health. Mr. Jimenez is part of the collegiate body of surgeons since 2003, and he has worked as a professional as the incumbent or post holder of the agency that measures disability from the Costa Rican Social Security authorities and its agencies as a coordinator for the Commission of Assessment for Disabilities to analyze the regimes or the types of the pensions offered by Costa Rica and its system. He also worked as a coordinator of the Constituted Commission to assess all the backlog and paperwork in agencies to provide social benefits. He's been also an expert in as an examiner, thanks to the Barcelona University, and has received major accreditations since 2021. Well, Dr. Jimenez, thank you so much. It's an honor for us to have you here. Thank you for joining. Thank you once again. Thank you, Dr. Hill. Now, thank you all. We thank the Inter-American Conference on Social Security Studies for the invite. Thank you for inviting us to the first technical summit of the American Commissions on Social Security. It's an honor for us to present this subject and to give you all the information along with the full development in our country, Costa Rica. Thank you. Next slide. Here, we have a focus, and we focused on the pension scheme. Today, I'll mention just a few topics regarding like the corporate bodily assessment to define the disabilities in correlation to the work risks. Now, next slide. Now, the national system is constituted in Costa Rica by law the following way. We have 4 pillars. There's the basic pillar of this constitution. We have the basic regimes or plans of mandatory insurance. Amongst these, there's another government agency that's the Agency of Disability and Death. That agency is part of the body of our institutions of the Social Security authorities, and there's coverage also during maternity leave. These 2 types of insurances or coverage that are offered by the authorities of Social Security in Costa Rica have under their command the assessment of temporary disabilities and permanent disabilities. So those are the assessments, and I'll explain each one later on. We also have other schemes in the system that are mandatory in the second pillar. By law, it's compulsory to protect the workers, and they have to be members to these regimes or schemes, and that enhances the services. It's the layering of services. There's a voluntary registration of the workers. They can decide to go through one option or the other option, having some taxes waived off. We have the other panel that's like the pillar of direct assistance. In Costa Rica, it's a scheme that's subsidized by government, and that system subsidized by government will benefit economically those vulnerable in our population which suffer risks, the elderly, people that live with a disability, people that have a common denominator when they're living in extreme poverty. And the institutions of states are there to solve that. Now, here we have the 5 main schemes that are part of the first pillar of the system. We have the scheme of invalidity and death. Costa Rica is a very small country. We have just a bit over 5 million in population. Our economically active segment of the population are 3 million, around 3 million, and the pension scheme and Social Security authorities have a great registration over almost 1.5 million workers, 1.4 million workers, and we correlate this scheme to the next scheme or measuring the members. The common denominator of all these opportunities or services and the laws that organize the system have led the Social Security authorities and these bodies or agencies that, this other agency is led by me, and I'm honored by that. But the Department of Disability Assessment is working permanently. We have a regime or a scheme of disability, aging, and death, as I've told you. And in Costa Rica, we had to go through the process of legislation till we created the scheme in 41, and then the enforcement of the new law. It was the General Act to protect the employees that, and out of that law, there's other laws, transitory laws to give certainty and social certainty to all the workers. So there's a way in which we budget of subsidized and tripartite. This is created by the employer, the government, and the employee. It's a tripart collective contribution. Next slide, please. Next slide. Okay, thank you. Now, discussing the Department of Disability, Aging, and Death. As the rest of the keynote speakers, I'll contrast my information with the rest of the countries. Later on, I'll mention it. But what we work with is a system that's pretty antique. So, but it has evolved throughout the time. So we've had the need to adjust, analyze, or assess international methods and incorporate them to our daily activities. We have the nomenclature and the way in which we classify and classify the workers in their environmental and social development. So whoever suffers any challenges, any person can be part of the system. You know, informal or formal workers or informal workers, whether they're formal or informal, it's mandatory for them to register in the healthcare system, which generates proper assessment from our side. So the employers have, I mean, it's not compulsory for employers they have to draft policies or internal laws and take care of the health of their employees, and independent workers sometimes are not incorporated. So we have to create the right labor profiles that are updated to determine the workers' capacity to work there. So next slide. We use classification mechanism. We have the process or a method in place in Costa Rica. Social Security authorities have developed using other tools and methods. We have surgical units and other departments that are part of it, but there's a long list of issues that are still pending. But there's constraints or limitations that some users have. Some users might not have access to some studies, or so we have the clinical case file of the patient and the situation that generated the pathology, analyzing their daily activities and their professional development. When we analyze a profile, we establish the percentage of capacity loss depending on the where of the subject. So we analyze key factors. Key factors of the person's assessment leads us to be deterministic about the clinical case file of the patient or subject that's studied, to have a feasible objective parameters to objectively rate the limitation or the percentage of disability that that person has, to be capable of executing his or her duties adequately in their work environment and in their communities as well. Next slide, please. Okay, so here with the CIF, we can assess. In this assessment, we have included different analysis. We sent them in a horizon of 10 years. We send them information about the Mexican Association of Medicine, and there's like a decree that's sourced from Spain and other methods to assess that we are using to assess any other factor to measure the profiles. So with these factors, we have to also assess other variables of the subjects that are studied, school levels, labor activities, and other factors, so they can execute their tasks and duties. So we've had to think about relocating a person if they have specific disabilities, and we rank or scan the person and correlate the person to a percentage of disability. The clinical file is basic, as well as the examiner's report and the findings or exhibits that are part of the case file that lead us to be really deterministic and consider other factors that lead us to assess the healthcare condition that the person lives with. If that person, that subject that we're studying, has specific profile and percentage of disability, that we have it all in the assessment. That percentage gives us a number for the formula or the expression to really rate or rank the profile. And in Costa Rica, In Costa Rica, we have scores to, if a person wants to obtain a pension due to disabilities, then they have to receive a score of 67 tops. Now, in this assessment, what's very important about these factors, the key factors are elements that we assess during the physician's checkup. The rest of what's procedural happens when there's involvement of insurance agencies. The subject that's being studied has to go validate if they have the option to ask for a pension due to disability in their classification, and when the user has that administrative right to be exercised, and due to his or her disability, he or she can't work, then they're sent to another social security agency for another assessment. We assess the subject with multiple disciplines, psychiatrists, forensic sciences, and other physicians in different areas of expertise. We invite psychologists for the thorough assessment to be objectively deterministic, and based on the clinical findings and the clinical case file of the subject, we can have a solid case that's grounded, and we build that clinical file, that e-file, and it's used in all the medical units of Social Security in our system. So that file is digitalized, and when it's the electronic file, we can use it to determine the history of the user, the subject of the assessment, to pay immediate attention due to the pathologies that he or she suffers, and those services are offered through Social Security. These factors of the subject's assessment is enhanced with the rest of studies that are also part of the case file to have clear findings and evidence, so we can assess the specific percentage of disability that's objective. Next slide, please. And here we have some concepts of disability. One, the improvement. Two, assessment of the subject. Assessment, and when there's no recovery, that assessment is focused on the capacities that the user, the person, the subject has. So we have the AVDs measured as a priority. When we determine the percentage of disability or pathology that each subject has or lives with, we evaluate different factors to measure the percentage, and we have a matrix and correlate the percentage to a value to measure the capacities or different capacities to generate a profile. So we have to be clear and objective in the assessment and prove with findings the percentage of capacity loss or skill set loss. Next slide, please. Here we have specific conditions that can limit us all. The lack of examinations from the clinical experts or the lack of a case file. That's why it's so important for us to analyze the clinical case file and the historic data of the subject, the person. And the key factor in those files are packed with a lot of documentation, other instruments, the clinical analysis, and then we use these to give a score or a percentage to issue the functional capacity of the subject that's object of assessment. We rank the skills, the cognitive, social, cultural skills, and we rank these all, and we measure it throughout a time period. Next slide, please, doctor. In Baremos, we have a labor code, the Labor Act that was drafted in 43. It's been object of amendment in 1982. This is a matrix in which we have the percentages in correlation to pathologies of osteomuscular nature. But in this code, we had some gaps. We didn't have information about the metabolic capacity, other organic factors and measurements, and that's why we had to go through the process of amendment and codify this to assess objectively with the proper factors to assess the subject when there's a loss of skill sets and functionality losses there. Next slide. Out of this code or labor code, there's a definition. That's what we use. In this slide, I'll explain with this slide the way in which we've constituted the method to assess the subject in correlation to the healthcare authorities and the insurance entities to measure the work rate related risks. If somebody's at work and they suffer an accident and they suffer a disability, at the workplace. If the disability is generated due to some activities or duties, there's a national institute that administrates the process of ensuring the subject in that's part of the workforce. So if there's work-related incidents or traffic incidents, or it's also part of the documentation of the law of insurances and other codes. Other insurance entities or bodies can decide to obtain the insurance services from different bodies that offer insurance services. We have the SUA, that's the mandatory insurance for when somebody has an issued driver's license. Whoever owns a car has to buy that insurance or hire that insurance. If the person suffers an incident and suffers a crash and they're suffering a disability, a temporary disability, they're protected by this law. And then the national insurance entity or agency is there. They go through the assessment. If it's a chronic disease, a pathology, or accidents, then they have to analyze the healthcare conditions through those agencies in Costa Rica and the national Costa Rican healthcare authorities. Sorry? You have 2 minutes, sir. Thank you. To determine the functionality, 1 minute just to celebrate the closure of your participation. So I'm sorry for interrupting you in such a way. Pardon, but thank you very much. And in the case of pensions, I mean, this could also apply or be used for the total permanent disability. In this chapter or in this article, we have to go through the process of all the phases to measure and assess the disability that the person has. Now, this is the baremo that I was talking to you about. It's a method. It's like the AMA, the CIF, or the medical associations to measure and assess. And now that I have the opportunity, I've had the opportunity to listen to the Colombian counterpart, our doctor, but baremo for us, it's a method. And we are using the most prestigious sources to be applied and to improve Social Security. Next slide. Here, these guidelines have been structured and they're constituted with 18 chapters. The tumor chapter, bone and muscular chapters, and how this is applied and correlated to other laws. We use the CIF or the assessment tools and use all the tools to and even measure environmental social factors to thoroughly scrutinize the subject and their organic functional capacities to execute their jobs or duties. Next slide. That would be it from my side. Thank you very much. Thank you very much, Doctor. And I apologize for having interrupted you. And I apologize for having that delay in our agenda. We had a morning that was very robust with many panels. Dr. Graciela, if you allow me to briefly read the list of participants due to time constraints. I don't know if those of you who have observations, feedbacks, or questions, you can submit those questions via email or via chat. And our expert panel members could submit a response or issue a response to your questions. Dr. Graciela, so could we have 2 minutes, ma'am. We thank all the panel members. It's been a great privilege. And it was great to discuss all these subjects which are so complex. We want to discuss at this round table, the efforts. It's not just, we don't have to just give a redress, giving a pension. There's a subsystem and there's multiple disciplines involved and many professionals involved, which are organized in these agencies or institutions so they can really issue or grant a pension. It's not that you're going to grant just a pension to any subject. That's why we're working to identify the real residual capacities that a person has, so we include them in the workforce, even if there's certain disabilities. And first, we have to assess, identify, and help them be part of the workforce and continue their development. We have to insert them, incorporate them, invite them to continue being part of the workforce and making our social security systems sustainable that way. With this, we thank you all very much, and it's a privilege and an honor, and we hope to get the opportunity to continue discussing these topics about how do you assess and rank disability inequalities and percentages, and the fact we know that in our countries we might have the need to broaden our capacities to develop our medical examiners or forensic scientists and to add value to all this work. Thank you very much, and we celebrate the closure of today's panel. Thank you, Dr. Graciela. Now we're going to have a brief change. We're going to change the panel and we'll continue. We celebrate the closure. We're going to celebrate the next panel. And we thank you all so much for being so patient. Thank you for, respecting the time frames, and we'll continue in a sec.
Afternoon to all the people that are still on site and person. Thank you for being here. This event is for you, and because of you, your presence gives logics to these activities. And thanks also to the people that are online that have been with us all day long from different countries and places that accompany and that are part of the member states. For this panel, I'm going to allow myself to give the floor to our moderator today, Mr. Emmanuel Araujo Dantas. Who's part of CAOSA, one of our commissions in charge of the administration systems and organization systems. He will be the moderator for this panel. Thank you very much. Thank you very much. Wow. Good afternoon, everyone. I will be here at CISS after almost 5 years. Or even 10 years, and now it's a great joy to be back and participate from this debate that simply is enriching. And today we'll talk about this panel about the new technologies and solutions for social security. And we know that after the pandemic that we had in 2020 and 2021, the world changed. We have a completely different world that has changed with these technology advancements that has been meteorical. And what was happening in the world with these advancements in technology from the pandemic on, that was intensified actually as a result of this social isolation and the ways of working, and it is important to have this debate that we have today, because in the last days, all these public spheres and private spheres have gone through these digital transformation. And I want also to say that these digital tools such as mobile apps, those electronic reports, AI as well, that has been a great advancement that actually is present in all the countries around the globe, as well as the administration administration of a great amount of data that have a potential to enhance, or importantly, the lives and services and access to all the beneficiaries of social rights and social security rights and so on and so forth. And at the same time, it may contribute to a more efficient administration or management, that we know that these new technologies contribute to a new, more efficient management, and also a transparent way to process and to use resources that are part of the social security systems. Nevertheless, they also generate some preoccupations or worries, because it is important, because it is related to the ethical use of personal data. Because that really actually happens, Well, there's a fragility mainly with this data. One more worry that we see, and that we've talked about a lot, mainly in my country, in Brazil, which is what the digital exclusion problem. that has had an impact in the productivity, employment, and of course, the acceptation and adequate use of tools by the part of people that are part of social security institutions, discussing all the benefits and risks of this digital transformation. Not only is not only enriching but also necessary, so that mainly for decision makers on the implementation of technologies and also for the general public, being aware of the arguments in favor and against digital transformation in the sector, and also the specific cases will allow a more critical comprehension or understanding, and mainly for decision-making processes, either political or technical decisions, in the search of the maximization of benefits and the mitigation of technology risks, and ensuring thus social security systems that are more equitable and efficient. And in here, I want to add a little detail. This digital transformation also increases or diminishes social inequities. We hope that information coming from this successful debate, which is very valuable among specialists, that so it may contribute to that objective reflection on the benefits and risks of these kind of tools, digital tools, offering a wide vision that would facilitate the political formulation of these areas. Once having said this, I will explain the way this activity will be carried out, this debate will be carried out. The dynamics is divided into 4 discussion blocks. Each block is presented by with an open-ended question and the context. 4 specialists will be able to talk about their points of view, reasoning, and experiences in a free way in 4 minutes, each and every one of them. So in total, it's 16 minutes. And after these 4 blocks, we'll have 56 minutes. Each and every person will have the chance to, who would want to have a question. We will organize the order of the interventions. In the end of the 4 blocks, I will give the floor for 4 minutes to each and every one of the specialists. In the end, we will have space for Q&A from the public. I will give these questions to the specialists according these questions are raised. So before we go to the discussion, I will introduce each and every one of the specialists. We have Dr. Patricia Mikhail. I hope this is the way we pronounce it. Dr. Patricia, she's a specialist in digital health. She has a master's degree in Science of International Health by the Johns Hopkins Public Health School, and Doctor in Public Health and Policies by a London School. She's a co-founder and leader of policies and uphold Sorry, I am not fluent in English, right? And an organization, a non-profit organization that helps with countries with low and medium income through the digital transformation. Besides that, she's the director of the Global Digital, and she has almost 30 years of experience in those areas. Nowadays, she's an associated teacher in the Innovation Center and Global Digital Health by the University of Johns Hopkins, where she worked in more than 45 countries promoting the adoption of digital technologies in public health. So Dr. Michael was awarded, she has been awarded several times, and for example, with one of the awards, I will talk about the Rockefeller Foundation. Dr. Alfredo Cabrera, he is the president of the Bank of Social Assistance in Uruguay. He is a doctor in law and social sciences by the University of the Republic of Uruguay. She has a master in entrepreneurial law and assistant professor of financial law. She was a member of the direction member of the Uruguay School of Law and the University of the Republic. He has been a deputy by the Department of Montevideo. He had been General Labor Inspector and Social Security for the Ministry of Work and Social Security, National Coordinator of the subgroup of labor relationships in the Mercosur, and government delegate before the ILO. Dr. Claudia Vasquez Espinosa is an engineer in cybernetics. She works with computing systems with La Salle University. She has a master's degree in data administration by the Barcelona University. And also she's got a business administration degree by the Anáhuac University. Professor Valdez has a wide experience in technology of information governance, analytics, data, business processes, and projects. She has been certified in project management by the Institute of Project Management. So she had also some leading functions and technologies of information and communication in companies like Scott Bank and Grupo Comex, Electra Group, among other institutions. Nowadays, she's the head of innovation and technological development of IMSS. Besides that, she has position as a vice president of the American Commission of Administration System in the Inter-American Conference on Social Security. We also have Dr. Alejandra Fernandez Vélez. She has a PhD in computing by the UNAM. Nowadays, she has a master's degree at the American University in Europe. She has also a diploma course in key areas of the health sector, including digital transformation, Columbia Business School, and also in high direction in Social Security. With more than 20 years of experience in the public sector, she has led technological projects in the sector of health in Mexico City government. Among her projects, we have the implementation of the information and medical registration, mobile registration system of the system of medical administration and training, and also the implementation of systems of electronic registry in medical units of first and second tier. Nowadays, she is a sub-director of technology of information from the Institute of Security and Social Services for the state workers. She's responsible for the digital transformation of 571 first-tier units, among other projects of that are pretty important. Once we have had this introduction, then I will give the floor to the first. I will give the first question. So, according to the ILO data, the covered population with at least one social protection benefit, without including health in the American region, was about 64.3% by 2020, with this great disparity between countries. As for the universal health coverage, was 78.7%. On the other hand, according to the data from the World Bank in 2021, 66% of Latin American and the Caribbean population would use internet. Nevertheless, the column for access to internet between the urban families and rural families in the region, it was greater than 37% in 2022. In that very same year, between 70 and 91% of the population of the Latin American countries would use cell phones, smartphones, depending on every country, of course. And by 2023, just 12% of countries in the region of Latin America and the Caribbean had a 5G network installed. So, considering this scope or this site, and then I will give a little parenthesis to talk a little bit about Brazil. Brazil is within this context that in Brazil, 84% of the population has access to mobile telephoning, and more than 70% of rural population also use the mobile phone. So, having said this, the question is, up until which point or which extent new technologies on themselves are useful instruments to widen the coverage and warranty the effective access to social security. So, having said this, I'll give the floor to panel members or speakers who may want to give us an answer. Okay, please go ahead. Dr. Claudia.
Gracias.
Thank you, and good afternoon, everyone. It's a pleasure to participate in this forum, in this debate. And then, definitely, I believe that, from my participation at IMSS, I can tell you that the Institute has going for
Es una
technology.
necesidad
It
que
is
buscamos
something
en
which
esta
is
implementación,
necessary.
poder llegar
We want
a
to have
toda
in the
esa
institute
población que pues
to
tiene
reach all
condiciones
that population that
muy
has
favorables ya, en cuanto a lo que es la parte de
disfavorable,
accesibilidad.
unfavorable
Prácticamente
conditions
el
in the part of
instituto atiende
accessibility.
casi
The
el 70%
institute
de la
works with
población.
70% of the population. So
En el instituto se
at the
tienen
institute, we
actualmente más
have
de 1.800
nowadays more than
unidades de salud.
1,800 units of health.
Y bueno, pues muchas veces las
So many
poblaciones en las que se
times the
encuentra la
populations
población
where we
no son
have
de fácil acceso. Entonces,
the
uno
places
de
where
los
the
primeros
populations
trámites que se
is
digitalizaron fue
are not easy
precisamente
to
esos que
access. One of
ayudaban
the first
a la
things that we
población a no tener
worked
que
with is
estar
those were that
haciendo
would
pues
help the population
traslados
not
que
to
implicaban muchas horas
um,
de trayecto, obviamente con
have
los
this
costos asociados. Entonces, bueno, pues empezaron a digitalizar
need to
trámites
go
como
from
es
one place to
la
another. So
parte,
we
trámites
started to
que normalmente se hacen
digitalize
en las
some
delegaciones.
paperwork and some
Y pues
paperwork that
digamos que así
normally
fue
are
como
performed at the
inició esa
delegations.
primera
So this is the way
etapa de
we started
poner
this first
la
stage of
tecnología
having
al servicio de
technology
nuestros
for the
derechohabientes,
service
¿no?
of our
Sin
beneficiaries.
lugar a duda, retos hay
For
muchísimos.
sure, there
Creo
are
que
many
el éxito
challenges.
de la
I believe
pregunta
the success in your
que hacías
question
era
uh,
la tecnología
was
por sí sola genera valor.
technology on itself
Creo que
generates value.
no
And I
precisamente.
do believe that
Genera
that's
valor
not
cuando
the
esa
truth. It
tecnología
generates value
la
when that
aplicas a
technology is
ciertos procesos
applied
que dan
to
valor
certain
para el
processes that
cliente. A veces has trillado el decir
give
que
value to the
el cliente, en este caso como el
beneficiary. So in
clientista que
this
soy
case,
yo,
the
pero realmente eso es lo
client
que
or the
buscamos, ¿no?
beneficiary is at
Buscamos
the
cómo
core.
hacerle
That's
más
what we
fácil,
want.
cómo
We want to
poner
make it
la
easier
tecnología
how
al
to
servicio
have a
de,
technology to the
y
service
bueno, pues
to these users. So
en
I
esa línea,
believe
como
with this in
desde
mind,
mi posición
from my
en el
position
instituto,
at
como
the institute
responsable
as the
de la
responsible
parte
for
de
the part
tecnología,
of
de
technology,
innovación y desarrollo tecnológico,
innovation and
pues
technological
prácticamente todas
development.
las áreas
So
son
all the
mis
areas
usuarios
are my
y
users,
pues muchas veces nos toca
So
atender
many times we have to work
requerimientos o sistemas
with
del área de salud, a
requirements
veces de la
or,
parte de
from the
pensiones,
area
de la
of
parte de
health,
cobranza,
pensions,
en la parte
collection,
social, los
social
sistemas para
part,
automatizar los procesos de
systems to
guarderías. Y la
automatize
verdad es muy
daycare
satisfactorio en
centers.
cada
And
uno
it's
de ellos
very
ver cómo
satisfying to
sumar, ¿no?
see
Por ejemplo, en
how
casos
to
de
add,
guarderías, cómo
how
hacer
to
que
be useful. In the case
los
of
papás
daycare
puedan de forma
places,
muy
to see
sencilla poder
how
hacer la
parents
inscripción de
very
un
easily
pequeñito
may
en línea.
subscribe a little baby
O bien
online. Or,
servicios como en la parte
services
funeraria, ¿no?
like the
Cómo
funeral
tenemos
services.
servicios que
And
generan
we have
realmente
services
un
that
valor en un
indeed
momento
generate
complicado
value
para
in a
nuestros
complicated
derechohabientes.
moment
Entonces,
for
¿cómo hacerles la
our
vida fácil? A
users. So,
través
how
de
to
implementar
facilitate
y
their
llevar esos
lives through the
servicios,
implementation
que
of
los
those
servicios puedan
services that
ofrecerse como parte
social
pues, de toda esa amplia gama de
the
cobertura de seguridad
IMSS
social.
offers
Y bueno,
from
como
these
que
social security services and
contestando,
coverage.
sí,
So by
definitivamente
answering your question, I would say that
genera
definitely it
muchísimo
generates
valor,
value, a lot
pero
of
tiene
value,
que ir
but it
pues
must,
entendiendo
go.
qué proceso es al que
We
vamos
have to
a
understand
aplicar.
which process we're
El
going to
proceso no es
tackle.
fácil, ¿no?
The
Porque
process
va
is
más
not a
allá
simple one because it
de
goes beyond
generar una aplicación.
generating an
Hay que revisar,
app.
nos hemos
We
enfrentado
have
mucho temas
to
de
take a look at it. We have
telecomunicaciones.
seen problems with
Creo que ese es uno de los
telecommunications.
retos más
That's one
grandes. Se ha
of the
avanzado mucho
greatest
en la
challenges that we have.
administración,
We've
en
gone
lo que fue la implementación
ahead
de
with administration and
infraestructura
the implementation of
de
infrastructure
telecomunicaciones a nivel
for
satelital.
telecommunications at a
Pero
satellite
creo que el
level.
gran reto son
And so the great
comunidades rurales
challenges are rural
donde
areas
pues más
where
allá para nosotros es muy
besides, to
sencillo, a lo
us, it's
mejor
pretty simple
normalmente nuestros
sometimes to
servicios
normally
los
our
tenemos
services
disponibles, los
are
podemos regional a
available
través de la página web,
through a
a
single
través
channel,
de
through the web
nuestra
page or
aplicación
through
digital
our
o bien a
digital
través de un call
app or
center.
even
Y bueno,
through
pues
a
en
call
zonas
center. So
urbanas y
in
más
urban areas, in the
tecnificadas es muy sencillo, porque
more
realmente
technified
retos
areas, that's
cómo
pretty
llegas
simple.
a
So the
ese tipo de
challenge is to
poblaciones
reach the kind of
donde
populations
pues
where
es
they do
mucho
not
más
have any
complicado, o bien
access
el
or
tema
it's more
de la
complicated
brecha
to have
generacional, que
access, or
también
even the
es una realidad que después
generational
de pandemia
um,
es
gap, which is a fact that after the pandemic, it boosted all this. It helped us to have a faster and smooth adaptations. We invested in technology. So I believe to start with the first round of questions, that's what I would be able to contribute with. Okay, Dr. Claudia, thank you very much. Now I'll give the floor to Dr. Patricia. Please be my guest.
Wonderful. Thank you very much.
Muchísimas,
And thank you for the organizers for having me. I'll only add a few points to what Dr. Claudia has said. Can you hear me? Oh, is there translation? Sorry. So technology can provide access, does improve access to different types of services. And as governments are moving towards more digital first social services, then I think, can you hear me? Okay.
Sí, yes.
Great. Okay. So I'm just going to add a few points to what Claudia mentioned because she did a very nice job covering this question. And I would just say that there are, digital divides that as, countries move towards digital first services, and a range of social services, that the way that they are designed can make it challenging for people who, one, do not have access to digital technology to connect and to use those services, but also, as she was mentioning, some of the generational issues. So older adults, people living with disabilities, people with mental health challenges, and refugees that may not want to be identified by a certain key sector segment of the government. So it's very important when thinking about the design of different services to take a pro-equity and a proactive equity approach that really looks at those who are connected, those who are not connected, and the different ways in which they engage with technology and provide services that are multimodal. So services that can be accessed, continue to be accessed in person, services that can be accessed through basic handsets, services that can be accessed through smartphones, tablets, and computers, so that the majority of the people can access those services. And what we're finding as well is that in many circumstances, a lot of the technologies are developed sort of by people sitting in offices without really engaging with the hardest to reach populations. And so I encourage those of you that are in the technology space or in the policymaking space to really invest in user-centered design and really identify the potential key stakeholders that might be left out, and then kind of design with them.
Muchas gracias, a doutora Patrícia.
Thank you, Doctor.
Agora eu passo a palavra.
Thank you so much for your comments, ma'am. Now, the floor is going to be open now for Dr. Alejandra Fernandez. Thank you. In effect, that could be a limitation.
Pues hemos alcanzado ya los 120 millones de habitantes
Pardon.
servicio de internet.
We're having some technical difficulties. I apologize. Thank you very much. Now, the quantification was, we measured what was happening in 119,000 communities in urban zones and rural zones. During this administration, in this 6 years, we have broadened the coverage of this analysis. We escalated from 75.5 and measured 95.6% of the population. And we're including 99,000 sites where they can have free internet access. And we're providing coverage to 2,400 municipalities of this country. That's why this is so important, precisely to make these services available, to make them be accessible for the population or the users, the beneficiaries that contact IMSS and other social security authorities, so they can have access, direct access to this technology. So definitely, the use of these new technologies as artificial intelligence, and the automatization of processes and the generation of indicators and data monitoring and analytics enables us to go through the proper decision-making process to make this effort certain. In effect, we have to go through the review or analysis of the needs that different users have in the context and analyze the context that they live in. And we have to create these services for them to access these. In the case of ISSSTE, we've worked to have the users have access to the daycare systems and other programs. When they have a medical appointment, we want to agilize or expedite the process so they can visit their doctors. We're using other devices like apps, other tools, devices, mobile units, and we're working at a local level too. But at a country level, I think that Mexico is leading its efforts towards the coverage of its total population. Pardon, there's some technical difficulties, ma'am. Thank you, because technology can enable us to improve the situation. I mean, that's essential. What we're doing is essential. We have to build the right mechanisms to improve. In my country, even if our territory is small, we are trying to provide 5G satellite coverage to make all these technologies available for the users. And pardon for being redundant, we want this to be accessed by the users. There is a digital gap between the elders in our population and other samples of the demographics. We're trying to generate everything in the digital realm of things, but trying to narrow the gap is something that we're working on. We have a program in which we include all the retirees or those who receive a pension. They can access the smartphone, and the smartphone is given by the public telephone service carrier. But definitely, what's important at a continental scale, I'll tell you that we're providing prepaid cards or prepaid services so the users can access to these systems if they don't have the resources to have access. We have created another virtual community. And in those communities, we can correlate virtual activities with tangible activities, and we build those communication channels. That gives us an example of efforts and proactive efforts. We have to use technology to improve the services and the benefits for our people. So in Mexico, you have your case of reference, but in Uruguay, the users can register online. The employer can register the employee or the worker from home. They have to go through the estimation or calculation of the payment they have to materialize. And definitely, I think that it's a good example. We're using the technology to formalize the process, simplifying the registry to generate a formal economy with different technologies. So I know I have 4 minutes, but I'll try to explain the type of technologies that we're using. When we're inspecting, we inspect and we have to use technology. We have to find the lawful means to inspect and to use apps. We use geolocation apps and tools. Without doubt, these tools are used by governments. So it's fundamental for us to do our job. Pardon, we're experiencing some technical difficulties with the material resources, the microphone. So we're analyzing how we could use mobile devices if we don't have internet access in like different zones, the urban zone and rural zones. And if we start thinking about building a strong security mechanisms, clearly we're trying to improve the access to all these services so we can digitalize the process. Now we're going to achieve this with these solid initiatives, but we must consider that there's people or users that have lower income. Now, because of this, if they're underpaid or have low income, they might not have access to internet devices and other material resources. What these users have to do sometimes is they're not included then. These users or members of the population are not included because they can't have access to technology or internet. You know, there's different technologies in my country that are being implemented. Now, I'd like to answer the second question that I've received. So I want to give you context. The next question is the following. We must highlight the strengths in digital tools, availability of the services, and obtain greater clusters of data. With the progress and use of IT or different tools, we can even be capable of visualizing the data that's object of the analysis. So we compile that data, and the laws enable us to generate a report that's confidential information of the users, and that's controlled. Now, the massive data compilation or the data that's produced, we're using big data. We compile the data using different digital devices or mobile devices, telephones, and all types of tools are used to compilate different types of data to simplify the process. We want to cut down on the response times for the user or the beneficiaries. We want to really create a personal way to communicate with them and strengthen the healthcare systems with these means. There's multiple ways to use the data that we obtain. For example, we are analyzing the case of reference, which is Brazil. In our country, what's happened is if we have specific interactions with the stakeholders, we can obtain the data fast. We can register the beneficiary or the user in the digital way or through interfaces. So he or she or the users can receive the benefits 48 hours later, the registration. Here, we have a list of existing benefits, and we ponder the risks as well of accumulating data. We find the right way to store the data and properly use it. So this has been developed to justify the means justify the consequences.
Vou passar a palavra para a doutora Cláudia.
Now let's open the floor for Dr. Claudia once again, please. I'm for it, for the use of technology. I feel a lot of passion, and I love data analysis and compilation. It's very important to have data governance that helps us draft policies so we can precisely keep control on the full life cycle of data compilation. So big data is what we're using currently. And technology evolves. It's cost effective. Now, there's other challenges that we have to face. It's that governance or codes that protect that information. We have to make sure that the information that we get is top quality. We preserve the integrity of it because of security. And it's extremely relevant. It's very important. What you just mentioned is extremely important. We think about the body of law or the legislation that plays a crucial role. That's matter of debate. And we have to create the proper initiatives for data protection. It's very important for us to allocate investment when we obtain data that's given to the institutes or the agencies. It's like 4 or 5 years ago, we constituted the data department, and that department in our apparatus has a task assigned. Their duties are to build a data management system that leads us to guarantee tracking, monitoring, quality, compilation of all the data that's sent. And we build the stratigraphy of a strategy. We're working towards that digitalization strategy. It's basic. Not only that, this data is basic for us. We have to protect the data. It's safety and security for all the stakeholders involved. That's the backbone. It has to exist in all the fields, because if we build something, it has to be solid, build on solid ground. Just to give you an example, how do we use data? Just to give you a case of reference, that data definitely adds value. There's different types. There's so many types. I would like to mention one project. We created the e-file or the clinical case file of the subjects, the users. We used it in big data. So we started enhancing or incorporating and adding and using the core processes. We went through like surgical procedures, urgent cases. So we started classifying these and branching the data out. The results from the labs to measure the disabilities, and we started analyzing the economic redress capacity. Right now, we're working on incorporating other layers of the case file or the clinical file, which are the captured images of the subject. And with all of this data, we can execute models and obtain predictive forecasted data. So with these predictive efforts with the models, we can digitalize this for the healthcare system. Obviously, this means that we have to administrate the data with a lot of care, and we need to buy top-level quality technology and obtain biometric data I mean, just like the banks work, we have to armor and protect the information, the information that's used in social security services, have to be objective audit, inspection. So if we want to grant a pension to someone, to a subject, we have to compile the data correctly. And the effort is justified.
So I think one thing that we have to make sure that we pay attention
Tenemos que
to is
asegurar que estamos dando toda la atención.
trust.
O sea, todo esto se tiene que construir con base en la confianza. Los individuos, los beneficiarios tienen que tener fe y confianza en la tecnología que ellos están utilizando y ellos
data is going to be used for the purposes in which it is collected. Now, increasingly, we're using data for multiple purposes, right? So we're not just using data for the individual purpose in which it's collected. We may be using it for research, to do more predictive analytics, to do more prescriptive analytics, and all of that, which is also very important. But we have to find ways to communicate with people about, how their data is being used and obtain the appropriate consent, and not do the 20 pages of terms and conditions that everybody clicks through, but nobody actually reads all the terms and conditions in which they are being, consented into. So I think we need to, simplify a lot of the ways in which we communicate with people and build trust in the types of, services that they are enlisting themselves into, but also explain to them how their data is being, captured and used, and for what purposes. And as Claudia mentioned, there's so much that is happening in terms of generative AI and big data and machine learning. And we need more countries represented in the global, AI world. Because right now what we're having is, an equity challenge between, high income settings where a lot of the basic AI models are being, designed and implemented, but the data that is there is largely in English. It's largely representative of, North America, Europe, and other high income settings. It does not account for multiple ethnicities, races, genders, etc. So we need to think more ethically and responsibly about how to, make sure that the way that we're approaching, data builds trust and confidence and is done in a way that is equitable, but from a global equity perspective. And so, I think it'll be important to think about how do we, in some ways, democratize data so that we're able to use data, but in a protected way to make the benefits reach many more people.
Thank you so much, Doctor, for your comments. Now, the floor is open for Ms. Alejandra, our next panel member, so she can express her thoughts. So data compilation enables the institutions to optimize the processes, cut down on costs, deal with procedural backlog. Those are part of the benefits when we compile data. I mean, it's customer centric with centralized. We can offer services for the individual users in fields of expertise in the hospital network to improve the user's experience. And it helps us all go through the decision-making process to strengthen the institution. Prospective forecasting is something that's also generated thanks to massive data compilation. We can use predicting forecasting models. At ISSSTE, the Mexican Social Security authorities, we've implemented the use of a model. And the data in the model can let us understand how we can supply medication. And we have supplied 95% of the medications needed to 95% of the drugstores that we have. So these models help us, or these tools help us guarantee the supply and anticipate and predict consumption. But we can also visualize parallel risks regarding privacy and confidential data. One of the risks that we can run into is the capacity to protect the individual's data. So sometimes, we compile data, and it's harder to guarantee that data is confidential, that it's not of public domain, that it's not used for different means without the full consent of the party that's affected or the user. We compile data, and the volumes of data are cumbersome, but there's institutions that are vulnerable, that they could be hacked. They could be object of cyber attacks. And some subjects could hack and obtain databases that could negatively impact the citizenship. Now, there's an erosion of the body's autonomy or independence, and we can perceive or analyze what's happening with the services. We have to understand the context. We know that the users, if hacked, can think that entities use their data without the proper transparency or accountability. There might be a perception of loss of privacy, wrongful use of data, or the wrongful use of data that's obtained. So from my perspective, I think that the healthcare professionals and those who use technology have to work together to keep that equilibrium. And we have to mitigate the risks and use what we have for the benefits. So in compliance with the standards of secrecy, availability, and protection, those are the principles that we use. And we raise awareness and constantly communicate to the involved stakeholders what we're doing with the technology that's available. And this is done with great precaution, ethic, and if the objective justifies the means, then it all depends, right? It depends. We have to think about the available resources to keep and armor the information or data. The benefits of digitalizing things and using big data could be very significant for decision making. Now, however, we cannot ignore the risks. Data use has to be regulated, definitely. There should be the legislation that armors and protects the user's data and rights under accountability, transparency. It's a fine line of equilibrium between privacy, data use, and the user's protection.
Now,
the floor is open for Dr. Alfredo Cabrera. Dr. Cabrera, could you share your thoughts regarding this? What we're doing, we're working, and there's some constraints. There's also some secrecy in the field of revenue, and with the Ministry of Revenue, we have to protect the patient's clinical electronic files, and there's a data protection law or act. Of course, it's not like an obstacle race, but I share this example as an analog scenario. We must protect. There should be an acceptance with informed consent. We can obtain a data so we can feed and source the statistic government agencies with that information. We have to build bilateral relations. And in these relations, one of the entities or counterparts, the user, the beneficiary might want to be awarded or given a pension. And then in the other stakeholders or entities might ask for the clinical patient of the patient, the subject. We're interested on what's happened to that subject health-wise. We have to analyze the root cause after the scrutiny or analysis or assessment of a doctor or physician, but that's part of the debate. There's a very interesting case of reference. There's a clinical file or electronic file with some medical certifications. We have to subsidize certain diseases, and some subjects abuse the system, and there was a general act drafted for the national healthcare system, and we analyze the patient's clinical case file, and then we audit that file and the subject to see if we can grant that subsidy after that inspection. So it's unthinkable not to use this. It's unthinkable not to use big data, because we protect the data and microdata. I mean, in a database can help us detect a disease that a subject is suffering, our user is suffering, and we can even geolocate that person, the profession of that person, and other data. So we can think about those contain secrets. We have to, protect that information. In pension schemes, and we asked the users to go to the consulate to guarantee that they're alive when they were receiving an economic benefit. Now we use geolocation services and tools to pinpoint or locate the beneficiary or the user. We can go from Afghanistan. It's very difficult to find your way in consulate in Afghanistan for a person to go to the consulate and prove that they're alive. So we can use other tools and mechanisms to know what's happening, to exercise law.
Fazer também rápido comentário sobre essa questão. Por exemplo, no Brasil, nós temos uma lei.
We want to talk about the fact that in Brazil, we have the General Protection Act. We protect in Brazil personal data. That general act or law does not enable the spread of that data in Social Security, because the data that's obtained is only for the use of our government agency, the Institute. We cannot just share personal data of the subjects, and we have the proper control mechanisms to restrict access to that data. We only use that data to create statistics without unveiling the user's personal data. There's another general law that protects the data's information of the user and the beneficiaries. Now, regarding the third question, here, I know that we're talking about the general context and the question that you just formulated. My answer is, when we think about the digital files, the electronic files, there's advantages. The advantages are greater than the risks. And this digitalization leads us to think that all the parties involved in that chain clearly agree on the use of these technologies. So all the stakeholders agree, and we can satisfy the expectations or the purpose. We can rank the use of these technologies as something positive. And this leads us to that digital transformation. If we observe that the data that we obtain is object of scrutiny, then it is. Now, the next segment of your question, what's the true benefit? Government officials, users, beneficiaries, those who have an insurance, and other stakeholders involved, employees, or, the employers and the employees and the different stakeholders that have an interest on this. I mean, the stakeholders have to be certainly open to adopt and use new technologies. and to have broader access to the services of Social Security through the means that we have available. What's your opinion? Let's go to the next panel member so she can give us an answer.
Well, I believe that as for the part of adoption of the use of technologies, we will never be able to minimize the challenge it means. I believe that we talk a lot about the change management topic, and I actually believe that ever since we plan a project, we are conceiving a service, we have to make an analysis, in this case, of who our public will be and who is going to be our final user, so that we will be able to guarantee that we have all the necessary conditions for these to be used and adapt all those systems. So actually, I believe that the pandemic made us be much more open to the digital topic, but there are challenges that go beyond this generational gap or inaccessibility. Many times we have resistance, we're reluctant to this. We have to break many practices, and definitely when we start using them, the people start to look at the benefits of this. So, but for sure, from the tech part, the greatest challenge is not the tech itself, but the creation or conception of a system. But many times, the fact that it would be used, it has been released and deployed. So the start is takes time, either for patterns or for the final user or internally even. It seems like it would be easier because we have a recent case. We deployed a hospital system, and in the truth of the matter is that in the first deployment, we realized we had to go 2 steps back, and before talking about the deployment in the 324 second and third layer hospitals, we had to work with obvious stuff such as warranty, the connectivity, and the fact of having electricity at the place, chairs and tables in the place. So because otherwise that's going to be some kind of resistance. So we had to pave the pathway to make sure that we got rid of all the barriers, and so this could be fluent enough. So by analyzing all those variables, we have good results. And this is just an example, We took 10 years to deploy the external consultation part in this group of hospitals. We had the deployment of these new hospital models that took us 2 years to prepare, and we have adopted and used more than 80% of this. So I believe this change management thing is pretty important. Thank you very much, Dr. Claudia. And then I'll give the floor to Dr. Patricia. Please, Dr. Patricia, be my guest. Well, Dr. Patricia tells us to excuse her. She had some stuff to deal with at home. She sends some greetings and gives the floor to the rest of the panel members in the room. So then I'll give the floor to Dr. Alejandra. We have 1 more minute. Well, I completely agree with what has been stated. So one of the main challenges is the adoption of technology. From my point of view, one of the main ingredients is that the senior direction would be committed with the implementation of innovation, of tech innovation, digital transformation. They must be our guide, the messengers, those that have to render the message. They will have to help us insert from an institutional point of view those technologies so that it will be adopted. Institutions require not only to have the technology but adopt it and have all the guidelines and the regulations and the whole legal follow-up so that this app would be recognized and used mainly when we have other technologies, parallel technologies that they even have to be enhanced or they have to be substituted by the tech obsolescence. So it is important to have this kind of support from the senior direction or higher management in order to be successful. We can talk about some examples. In the case of Mexico City, I had the digitalization of the 32 hospitals from the ministry, and we went from the typing machine to the computer. So we hadn't been able to do this without, from the senior managers. They didn't have to, hadn't accepted this project, and so they would have helped us to have this change management process. And the other important part was the participation of the unionized workers that they have to be immersed in the digital transformation process. Unions have to be immersed in this process so that they will help us with the adoption of these technologies, mainly in the most sensible areas, which are the clinical ones, because in there we're touching the process of clinical attention. So those are ingredients that must be taken into consideration together with the strategy that should come, the part of even digital induction. We have used this part in teaching people how to use appliances, the computer and tablet and the phone and the internet. What is the internet and what's the intranet? So give them these messages that will allow them to locate them in a digital culture which is homogeneous, and then later on go to the part of the awareness or sensibilization that will allow us to explain what are the purposes and the scope of the project, and from there start with the training process, on-site training process, following up the generation of guidelines and regulations that would make this instrument to be useful and the one that they would have to use. And in this way we were able to transform. And I will repeat, we went from not even having networks or telecommunication exchange to an institution that now is 100% digitalized. And on the other hand, at East, we have had examples of such as the medical digital permission in 36 months. So we went from the manual and written licensing to the digital one. So it is what this strategy that we were able to be very successful. And today, the percentage now is minimal that we have today in the part of permissions or licensings. And we, as I said, scheduling consultations that is for our users, not for our workers, but our beneficiaries. And also there we have to work with this culture of digitalization so that they will also adopt with ad hoc messages, considering the differences of age, context, so on and so forth. And this is why we use multi-channels. We only have internet and mobile app. We have the portal, we have the web, the call center. In this way, we then will be able to reach more population according to each and every context. It's a complete challenge to be able that an app will not only be efficient, but it would be also used. Thank you very much. Thank you to Dr. Claudia. I think our users are much more keen to the use of technology than what we actually believe. It is true that we must keep an analog model for people that are not keen to digitalization, older people, people older than 60. I believe that people in their everyday life have incorporated technology, and if we offer those tools, they will take them. Just to give some example, in June, in Uruguay, we attended in person 137,000 people, and through the apps we generated 147,000 actions by the people entering the web page. Registered users, 3 million of interactions. Without registered users, 800,000 people. We sent 2 million SMS. We had like 90,000 calls in a country with 3.5 million inhabitants. 6 million people had remote access in June 2024. 137,000 were in person. So we see what the trend is. We see the people that ask for a number, and we see the people that like to charge their retirement payment as a social act, to find their friends and go to the cashier and get their money. But most of people, use those options, and this allows us to optimize the time of our people in those activities that give a greater added value. So definitely we give loans to patients. Those loans were given in the bank through a document charged in the cashier. So they are decentralized now. So an operation that is reduced to see if they can take a loan or not. We took them off the bank and did an office in the interior, gives us the 50% of the paperwork that was done by a functionary, a worker. Talking about our users, people take this services. And then what we're going to have for next round, the digital transformation is not an expert matter subject, and neither from the area of systems of the institution. That would be the summary for next question. That's a challenge to organizations and their people that we have to assume. But indeed, I will continue with this in the next round of questions. If you allow me, I'm going to read a comment breaking the rules of this game. It's by Jose Angel Castro. He's one of the commissioners for CAOSA, and I want to say that he's been online for the whole event, and he has just sent a comment, and I'm going to read it if you allow me. He tells me technological advancement has transformed deeply our societies, offering great benefits like the enhancement in efficiency of services based in health and education, tailored education, and new economic opportunities. But we understand that it makes us worried as for social and exclusion gaps. The use of new technologies may amplify inequities if we do not work them properly with the regulatory frameworks and public policies. Those that have access to technology would go faster than those that have less resources that would be taken apart. So we have to be proactive and act. Having said this, the benefits of technology may overcome risks if inclusive strategies are developed, policies that will have equal access to technology, training in digital abilities and investment and infrastructure. These may reduce the gaps if we take advantage of the potential of technology with an ethical point of view and an inclusive one. This may be a powerful tool to diminish inequities and enhance the quality of life of people. But this is only going to happen if we address this intentionally with all the barriers of access and the risks and problems that this implies. Thank you very much. May you please continue with next question? No, after this, I'll go to, what do I go to next question for, you know? Well, and I'm going to give the next question. Many times we have digital technologies as a solution for many of the challenges that we as Latin American and Caribbean countries face in terms of coverage of social security and effective access of the rights that the workers have. Among the multiple advantages that we have just mentioned is the reduction of waiting time with a better quality of services, reduction of costs of operation, greater transparency in the management and the resources, among others. Nevertheless, how frequently these technological tools generate greater efficiency of the social security systems, considering the necessary resources to have the development through the implementation of actions, in which aspects, specific aspects, can we have a better efficiency, and what things have about this, and how can we measure this? I will give the floor to Dr. Claudia. Thank you very much. Well, I believe that here a paramount aspect, and referring to what Alfredo mentioned in this answer previously, I believe it is paramount that projects in the part of digital transformation shall not only be an initiative from the IT areas. I believe so. I believe projects with the greatest benefits and that are successful is indeed when we work in a transversal way between the different areas. I think in terms of social security, the line is a very, very fine one between a process and another one. So let's take an advantage, an example of our case, a product that was expressed, launched, the part of COVID permission, which is a digital permission. We had never had something like this because it would imply a medical exploration when, you know, you didn't even have accepted the digital consultation topic, the first medical gap. Obviously, you needed the patient, so the situation and the sanitary emergency where we all have a genuine objective, which was to save lives. So this helped us through questionnaires and made by the medical area. That would be the entering point, working with the part of incorporation to see how we are going to make sure, you know, that we didn't have identity supplantation, and the part of economic support. How would we make sure that we were giving the resources to the right person? So we had certain validations that would allow us not to be to risk. So finally, the project was a reality. Almost 80 million permissions or resources were granted through more than 60,005 permissions. More like than the emergency point, it's being able to have these people at home without propagating the virus or the disease. And then this was, a cornerstone in order to adopt a technology. So I believe that the greatest challenge for this was it took 3 weeks only. So I believe that digital transformation, one of its pillars is transversal and collaborative work. So when it comes from those areas that work as a team, breaking those barriers, that helps a lot. So I do believe that the value that we can see through different apps, either for medical areas or the collection area, that would really help us. It helps us in the part of empowering our beneficiaries part. So I believe it is important that those products are conceived and they're always leveraged by the sponsoring areas of these projects. Thank you very much, Dr. Claudia. And then I'll give the floor to Dr. Marta. So I think it is very frequent, and actually, the pandemic was an important breaking point for tech development and the rendering of services. We worked in that time was a part of personal loans through the internet, being able to offer our beneficiaries to have a personal loan without going out of home. That was one of the main challenges among others, but I do believe that it allowed us to give the services. One more initiative was Assiste, that today through this multi-channel solution we generate more than 30,000 consultations per day. So we've been very successful when generating more services every time. We started with scheduling, and nowadays we are at a stage where we want to have the electronic unique file, which would be the constants of the pension simulators, among others, and like take the mobile telephone, the loan offering. So I believe this means, and by having in the pandemic saturation in our virtual office, we saw it necessary to have more channels in order to render greater possibilities and greater, proximity to our beneficiaries. So we have some other services, the part of portability for the part of pensions, which is an exercise that we have had in this administration. And I do believe that we have to mention it because we then may get the calculated weeks in both institutions and generate our beneficiaries the possibility to adapt their time and have a unique pension considering all this time they have been working. And of course, within the specific aspects that are used to measure services, ISTE has one of our digital services, which is a system for to have citizen requests, and this through these systems that we have, our beneficiaries may generate a favorable or not opinion, make a suggestion, or maybe congratulate, or and this means allows us to measure how efficient we are when we give the services. So this service is given through the assisted solution and from WhatsApp and the mobile app. So it's been a complete success because today we've been able to measure the satisfaction level. We are able to know if a patient was granted his whole recipe or if he only was partially attended. So in this way, we can monitor not only these through a portal that monitors the drugstore services, but the satisfaction of users. And we have a 90% of satisfaction, not only for drugstore services, but the satisfaction when they have this service. So I think that this is topics that are useful for measurement and assessment of services and social benefits. Thank you, Dr. Alejandra. Now I'm going to give the floor to Dr. Alfredo Cabrera. Okay. Regarding the previous question, I believe the question that we have to say, no, to all questions, that the answer is yes, we're more efficient. It's easy to show and quantify efficiency in the amount of services granted and better information, diminution of fraud. So there's many variables, and it all depends on each and every institution to define and say that applied technology turns us more efficient. So multi-channel, the use of means of communication and immediate research through WhatsApp when the person goes away. Those strategies that we all know and use, we have in our use agenda for sure. They make us more efficient. Now, I believe that the tech transformation has to be appropriated by the staff. They should appropriate the concept of communication. I suppose that many people, from the defining the solutions by experts, and you get happy. And after that, you see that there are three things that they didn't understand, that then we have to start again because that was not understood. And then after, what happens is, after this has been developed, then it's pretty good. We don't tell our people the virtues of using this, the good points of using this. And then the change management and resistance to change, which many times comes together with the use of technologies, because false dichotomy of, to my opinion, in the area of work, the application of technology, but it's always on the table, and it's not common that in the platform there will be greater technology, and all of a sudden we have other kind of things. But there's a great responsibility to convince about digital transformation. We must be continuously showing the virtues that digital transformation has. So these are our organizations. We had a first step. So we took those papers and we transformed them into a digital record. It had the same logics. So you would take this. Now it is done with a an electronic system. You forget about paperwork. So naturally, we have to, we're all, but the point is that we have to accelerate and go to the end to the transaction systems. And definitely let's retire people by the stream of transactions. So what we think is another part is the use of technology. No, we don't. We still need to have years with this is substituting some formats that we have digitalized, but definitely this is something which is not perfect. Private workers in the rural areas and interior of our countries, and sometimes we go straight forward and we see that this trend is not so efficient. So I believe that's the purpose that we have to go through. And during the pandemic, we were forced to go forward, forcedly, definitely in the second hour in 2022 with the Omicron variant, with the vaccine that was already there. People didn't die, but they got sick, so that generated a series of medical certifications because people were certified, and we generated an entrance so that in the mid tell you had that certification.
But I mean, a physician could not go to the person's house to evaluate if he or she was suffering COVID. I mean, I think about the false negative and COVID and the results. We're using technology to solve a problem. There was the issuance of doctor certification for the employees to continue working. I think that definitely we have to continue down this path and transform and use the technology and the means available. Thank you very much. Thank you so much, Dr. Alfredo Cabrera. And now, I believe that I think that we've consumed all our time, but I'd like to briefly comment what's happened throughout this debate and all the comments that were part of the dialogue. So I think that all of the benefits of the what's being offered, we have many options, many projects. So precisely during this digital era, the digitalization process, if we think about the past way of working, what was procedural, all the paperwork, now everything's like paperless, it's digitalized. Now, precisely that, in that process, we have to consider the users, the beneficiaries of the system. So all of that information had to be on paper, and it was a major challenge for Brazil. And obviously, the process of digitalization works right. It's part of it. So we have to digitize all of the processes, and the ministries of health or the healthcare authorities are working along those lines to progress and use digitization controls and to have control of vaccines, controls of physician appointments. And today, we have developed a tool that's an app in our healthcare system. Our beneficiaries, the users, can follow up and track the process of development. So I'd like to thank you all for allowing me to moderate the panel. It's been an honor to be part of this event. And I'd like to thank all the panel members, all the stakeholders for sharing their thoughts, their comments, and thank you for your thorough explanation. Sir, the floor is yours. So we thank you, Emmanuel, Mr. Argujo, all the panel members. Thank you. We thank you, sir, for moderating the panel. I'd like to celebrate today's closure by first, I acknowledge all the member states, bodies, and authorities that are part of the commissions. You built the great concepts, you analyzed and elected the panel members and the content. It's thanks to the member states that this work has been done. We thank all the Department of IT Systems and the different departments of this authority that have been involved. We have the president of the Social Security Board of Antigua and Barbuda, Mr. David Matias. Thank your commission. We thank all the members or commissioners of that commission, and thank you for enabling this technical summit to take place. We thank all the members of this commission, the Costa Rican Social Security authorities, the Mexican Social Security authorities, the Brazilian Social Security bodies, and other social security agencies from different economies. We thank all your staff, all your members, because those who constitute the commissions make it all happen. Thank you all. I'll repeat, all the institutions, so it's all in the official registry. It's the Mexican Social Security authorities, the Pension Authority of Costa Rica, the Ministry of Health and Sports of Bolivia, the Social Security authorities of Peru, the Social Security Services of the Workers of the State as an association as part of this commission, and the General Department of Defense of the users or beneficiaries. That was another commission that participated here. We have the participation of the president of this commission, Mr. Avela, and we thank the American Commissions of Risk Prevention at the Workplace. We thank the chair, Dr. Graciela Gil Montalvo. Thank you, ma'am, for moderating the previous panel. We thank all the members that constitute this table and this session, the superintendents authorities of Dominican Republic, the Social Security Agency for the state employees that were very active and helped this commission, the Ministry of Social Security of Brazil. We thank the Mexican Institute of Social Security that's also at this table, and they're at the work table of work-related risks with Ms. Velasco. She already apologized because she couldn't join the session, and the Costa Rican Social Security Unit, as well as the other agencies of Costa Rica. These three commissions have been working for 3 months. They had sessions and debated the topics to discuss here. They elected the panel members and the topics to be discussed here. Thank you all for having gone through these 3 months of hard work. We thank the General Secretary that's led by Mr. Álvaro Velarca. Thank you, sir, for supporting us with the rest of the American commissions. We thank you all for following. We've done this or hosted this event for all of you. Muy bien.